expert speakers tonight, so that we can get you those answers as they come. So thank you all so very much for joining us tonight. As you may have seen, we're going to be talking about health equity and what does that mean. Back in November, we opened this sort of health equity conversation with an Health Equity 101. It seems to be sort of this buzzword that's going around, and we know that people might not understand completely what we mean when we talk about health equity and what equality might look like in medicine. So when talking about cancer, equity is when everyone has an equal opportunity to prevent cancer, find it early, and get proper treatment and follow up after the treatment is completed. We believe wholeheartedly that everyone deserves to be treated equally. Some factors that lead to health disparities include poverty, socioeconomic factors, lack of trust in doctors and medicine, low literacy, and inadequate health insurance. This and other non-medical factors create barriers to accessing good care along the entire cancer continuum, from prevention and screening through treatment and end-of-life care. And tonight, we'll be talking and taking a deeper dive into this issue, hearing from experts in this field. Our greatest hope is that our listeners will walk away really understanding what we mean when we say health equity and the impact it has, particularly in the United States, although it is a global problem. Barriers to healthcare from a provider, systemic, and patient standpoint, as well as what could potentially be done to address some of those barriers. Tonight, our expert speakers are Monica Baskin, PhD, Assistant Vice Chancellor for Community Health Equity, Health Sciences, Professor of Medicine, Division of Hematology Oncology, School of Medicine, Associate Director of Community Outreach, Director of Health Equity, University of Pittsburgh School of Medicine, Hillman Cancer Center. We also have, I'm going to mutilate your name. So I'm going to say Dr. Dagogo-Jack, who is an MD and assistant professor of medicine, Harvard Medical School, a thoracic oncologist at Massachusetts General Hospital, and then Henry J. Henderson, PhD, senior manager, medical science liaison at Foundation Medicine. Before we begin our conversation tonight, I'd like to ask each of you to give us a little bit of background on who you are, other than those titles that I just described of you, and why you feel this is an important topic for you to be discussing with our community tonight. And Dr. Henderson, we'll start with you.
Oh, perfect. So outside of my professional career in my cancer biologist training, I like to think of myself as an avid hiker. I'm a dog dad. I'm the cool uncle. I'm a brother, a son, grandchild. And so these are all things that I take with me every day to work when I'm out in the field doing education sessions around cancer. And specifically, why this is so important to me and I didn't learn this until later on in life. I knew I wanted to learn about cancer and wanted to study it because it's so interesting. But it wasn't until later in life that I realized I had a personal connection to cancer and how it affected my family. I know we're at a lung cancer session today, but in my family, prostate cancer is extremely prevalent, tracing it all the way back to my great grandfather, who I'm named after of. And so when I made that correlation between my family history and the disease I really love to study, I think that's kind of propelled me into this field. And so having conversations like this, I think Danielle kind of alluded to this in the beginning in her introduction, is having an empowered patient, right, can extremely increase health outcomes, and how patients are received within the clinic. And so tonight I'm really, really excited to join two other experts. And Danielle, thank you so much for giving us this opportunity.
Thank you so much for being here. Dr. Baskin, how about you
Sure. Likewise, really
now?
honored to be here and to have this conversation. Similar to my colleague, Dr. Henderson, I think, I'm here for the basic fact that, cancer really has devastated a number of people in my family. And certainly there are a number of health inequities that we have an ability to really reverse course on. So for me, it was, losing my father to colorectal cancer when I was a senior in high school, and recognizing that he passed very early, prematurely, from a cancer that we know is preventable. So it wasn't until later in my academic career that I, started learning more about cancer and realizing the disparities that exist between certain populations, and then recognizing that some cancers end up happening a lot earlier in certain populations. And so I've, devoted the last almost 2 decades of my career to really focusing on health disparities and honing in on, what we can do to both prevent cancer as well as ensure that there's more equitable care and survivorship. So really delighted to be here to try to help, both patients and their caregivers to learn a little bit more about the disparities and what we can do about them.
Thank you so much. And last but not least, Dr. Dagogo-Jack.
Thanks. So it's wonderful to be here, as said by everyone else. I just wanted to follow up on Dr. Henderson's point and say that he said he's the cool uncle. I'm the less than cool aunt, but I own that title wholeheartedly. And so for me, I'm very excited to be here as well. I think for me, this is a very important topic. I've been interested in oncology or kind of cancer for a while. I spent part of my teenage years growing up by St. Jude Children's Hospital. And so I think that was a really eye-opening experience, right? You see a heavily resourced, what having a ton of resources can do to advance the science and to kind of alleviate the burden of suffering. And so kind of I shifted or pivoted from that to do some of my medical training in the south side of Chicago, and then coming to like Boston and seeing how different settings and different environments can actually impact the type of care you receive, and then the different strategies for communicating with diverse patients. And so to me, I think that this is an incredibly important topic and something that I think everyone can have a role in kind of in advancing.
Thank you all so much. I mean, I know for all of you and myself, and I know all of my colleagues at GoTo, cancer and a diagnosis and living with is very personal to all of us for one reason or another. So I just want to give a very heartfelt thank you up front to the three of you for agreeing to be here tonight to have this oh so important conversation. And with that, I think we'll jump right in. And Dr. Baskin, I'm going to start with you and just ask from your perspective and opinion, what does the overall health population look like in the United States as it pertains to health equity, access to care, and health outcomes?
Yeah, thanks for the question. I think that what we know is that there is quite a variable distribution of both health care as well as differences in health outcomes across the U.S. population. That individuals and populations that are historically marginalized, so typically folks of color, individuals who are sexual and gender minority, individuals living with disabilities tend to have worse outcomes when it comes to cancer, as well as many other chronic conditions. We also know that, historically, individuals who might be living in poverty or have lower income, as well as individuals in rural areas, really don't have the same type of access, and because of that, they typically will have worse health outcomes. So there's not an equal distribution of health, if you will, across the U.S. It really does come down to, in a lot of places, your demographics and a lot of times where you live. That makes the difference between who's healthy and who's sick and who's more likely to have a greater chance of survival from cancer and other conditions.
Yeah, I think it's really important. I think, and we're going to take a little bit of a deeper dive into some of these, I guess, non-medical factors that you sort of, kind of touched on a little bit in your answer. And Dr. Henderson, do some of these non-medical factors play a role on outcomes? And is there evidence to show that that is true? And when I say that, I mean we're talking about social determinants of health. So before we get into the evidence, maybe we can talk about what we mean when we say social determinants of health.
Yeah, of course. And thank you for that question. And I like to kind of paint the picture of when we're thinking about lung cancer specifically and thinking about social determinants of health. I kind of think of three pillars, right? Screening, risk, and treatment. right? And so for risk, we know that smoking is the number one cause of lung cancer. But if we take a step back, we have to think about how most underserved communities have more tobacco merchants, right? So we know that smoking is higher in populations where they have less than a high school education. We know that low income communities have a higher rate of smoking. And so if you think about this in a community perspective, underserved and marginalized communities suffer the most when it comes to risk, specifically in tobacco use. Thinking about screening, screening can reduce lung cancer deaths by 20 to 26%. But we know that only 5 to 6% of those people who are eligible for screening actually get that screening. And so if you can imagine if that low of a percentage is not getting screened, what does it look like for health outcomes as far as morbidity and death rate and survival rates, right? And so all of these things are combined and intertwined like a kind of a quilt, right? A quilt is basically tons of little pieces of fabric all pushed together. That's kind of what the social determinants of health are. They're pieces of, information, things that happen outside of a health factor, traditionally when we think about it, but thinking about things like socioeconomic status, education level, where our neighborhoods are located. There's evidence and there's studies that say that your zip code can really tell you how your health outcomes will be. And in the United States, it goes back, from the history of this country. And so I think you kind of wanted to stop a little bit before we actually get into the evidence. But those social determinants of health kind of really set the precedent of how we look at health outcomes in general.
And I love how you sort of started your answer talking about the screening, right? Because we know where in certain cancers where there have been successful, rates of people being screened, i.e. breast cancer, for example, right? Colon cancer is another one that I think of, prostate cancer. These are the things that your primary care provider more often than not is reminding you about and sort of pushing you to go and do. And yet still, when we look at the averages, as you sort of pointed out, being 5 to 6% in this population, um, it, it's a huge problem. Before we jump into some of the evidence-based sort of confirmation of what we know, um, Dr. Dagogo-Jack, what are some of the social and structure barriers, sort of themes that we see that sort of lead into that evidence and what we're actually looking at?
Yeah, I think that if we kind of build off of what Dr. Henderson has said, right? So if we talk about screening, for example, the gatekeeper for screening is the physician, correct? And so someone has to refer the person for screening. And I think that there have been numerous studies just talking about kind of how certain populations are less likely to be referred for appropriate tests, screening studies, because there's a precedent of having in some people having a mistrust of the medical field or clinical trials, et cetera. I don't think that there's this assumption or this stereotype that is the case for everyone. And so people don't bring it up. And there's studies showing that people are not having the same conversations with all patients. And similarly, I think another thing is that we see with early stage lung cancer, there's been multiple studies showing that even for resectable lung cancer, depending on where you live, depending on how you look, you might get different care for it. And having a kind of discrepancies in care translates to discrepancies in survival. Another type of kind of social barriers that depending on where you live, depending on are you able to get off work today to travel for your appointment? If your appointment is 3 hours away, are you able to get childcare? Are you able to pay out of pocket costs? Do you have insurance that will allow you to participate in clinical trials to pay for the therapies you require? I think these are things that we tend to gloss over, but they're very kind of fundamental to thinking about like the framework or the quilt of health, as Dr. Henderson has said.
Yeah, I think that's so important. So you touched on a couple of things, one being sort of geography, right? And I think that also includes and can be expanded into, conversations about differences in environmental exposures, limited access, as you you touched on to specialty services, maybe inadequate medical facilities, particularly in more rural settings and environments, lower education levels, literacy, health literacy. You touched on health insurance coverage, right? Either under and or non-insured individuals and it might be because of lower paying jobs, which sort of equate to inadequate coverage, immigration policies, of course, that limit working and having access. We can go on to larger issues of Medicaid expansion. And then two other sort of pieces to that, I think, are what I think most people don't really think about. And I should stop and say, having these conversations, particularly over this last year, but more in particular over the last couple of months, I have learned so much, especially as it relates to variations in like cultural norms. Like people have different beliefs, different practices, different communication styles, and then on top of that, all of the information that I've kind of dug into on provider bias or implicit bias, right? So, do one of you want to kind of jump in on the provider bias or implicit bias, and maybe give our viewers a quick sort of overview and explanation what we mean when we say implicit bias? Anybody? Nobody?
Yeah, I mean, I can certainly start on that, and I'm sure my
Mhm.
colleagues can add on. I think that when we're talking about some of the provider biases that might exist, I mean, so we everyone has a bias or has several biases, and it's based on, our background and what we've been exposed to. So it's kind of our mind's way of a shortcut to sort of when you don't know, you go into a new situation, a new person, you take what you've learned and your experience, and then you sort of you know then you assume that the things that you've had and the experience you had in the past are reflective of the person or the situation that you're in. And so I think what we know from the literature is that this occurs when you're talking about healthcare and oncology care as well. So people might make an assumption because of your educational attainment or your income status or your insurance status, your race, your ethnicity, your gender, that you may not be compliant, for example, with a treatment, or that you might not want to be a part of a clinical trial or make all these assumptions. And so that has been shown to be detrimental and to lead to differential care. So if a provider believes that you're not likely to follow through with their recommendation, they're not likely to prescribe you to that type of treatment, which may be the best treatment for you. So we do know that there are ways to mitigate that bias, that there are definitely both educational and training and supervisory kinds of interventions to make sure that those biases don't in fact lead to negative outcomes. And certainly that's something that we need to continue to advocate for.
Yeah, and I think it's interesting to think about, and what I want people to know, and maybe for one or all of you to comment on, is implicit bias is not something that people necessarily know that they're doing, right? So if we could touch a little bit more on that and sort of the cultural sort of aspect and what we talked about, the cultural norm for maybe the provider, maybe all that they know, so they don't even recognize that they are sort of pushing this type of bias, I guess, into the equation when it comes to decision making.
Yeah, and I can kind of start with, I love kind of giving examples. One of the things about cancer is that the patient should have a decision in their journey, right? That is their cancer, is their health. They should have a voice in the decisions that's being made. But most times, when you think about bias, whether that be implicit and unconscious, you think about all the information that you need to make a decision. To make a decision, I need point A, B, and C, right? In some cases, and there have been some stories where physicians leave out information because they believe the patient, where their education isn't high, or it's their skin color, or it's the way that they talk, their dialect. They leave out information that will be pertinent to that patient's journey, that patient's decision. And so instead of getting that patient A, B, and C, the physician only gave the patient B. And so they're leaving the hospital or leaving the office with a limited amount of information about their cancer, which is an extremely complex disease, right? Tons of big words, tons of fancy jargon that they probably have to go home and Google. And so these are things that are commonly happening in the in our regions, in the places that we live. Physicians leaving out information because they see a patient may or may not, and they don't know that, but their bias is keeping them from disclosing all of the information that's needed for that patient to have an active decision in how they want to be treated. And so I'll let Dr. Dagogo-Jack kind of comment if she wants.
Yeah, I think that was a great example. I think another example kind of harkens back to the clinical trial discussion, right? Or even molecular testing, things that are fundamental to the practice of thoracic oncology, right? A lot of it, perhaps the most overt manifestation of an implicit bias is a stereotype, right? To say, this person is a heavy smoker, this person has this, they're not going to benefit from this, so I'm not even going to send this test. Or this person, based on their socioeconomic background or kind of status, they're not going to want to drive here for this trial, so I'm not even going to discuss this trial. And then someone comes in a few minutes later with the exact same molecular profile, the exact same cancer, and you heavily present the trial to that person. And so you're depriving one person of an opportunity versus another person. And so a lot of scenarios aren't as overt as what I've described. Some of it, as we've discussed, is somewhat ingrained, somewhat involuntary. And I think that somewhat that we have blind spots to it. And I think that's why it's important with the push to kind of understand implicit bias, get the training out there, get the education out there for people to take a step back and realize that they, as we said, most people have bias when it comes to something. And we need to kind of rewire our thinking. And instead of kind of making automatic judgments, it's almost kind of out of balance to what we've been taught in medicine, right? Where you don't have a lot of time. You have to think quickly and make quick decisions. To almost take a step back and process things and say, why am I thinking that way? Would I have done this for this person, this other person in that scenario? And I think it's a new way of thinking, but I think it's very important for us to achieve equity in care.
I don't disagree. Dr. Baskin, do you have anything to add?
Yeah, no, I absolutely agree with my colleagues there. I think that yes, a lot of times this is not conscious, but it's based on, practice and so forth. And and just to further elaborate, the evidence on the clinical trials is that there are individuals that historically have not been represented in those trials. And what the literature has bared out, some of the work that we've done in this area specifically has shown that if you approach individuals, lower income, rural areas, racial ethnic minorities, and explain, very carefully in lay language what the trial is about, they are as likely as other individuals to enroll in that trial. But it's just as the example that was given that you make the assumption that they won't do it, and so you don't even offer it. And I think that's why some of the differential care happens because and again, the provider's probably thinking, oh yeah, I'm gonna spare this person, I'm not gonna go this way, but it really is providing differential care, and as a result, likely to have differential outcomes and survivorship as well.
Yeah, it's interesting, and my brain is kind of circling right now. But as I'm thinking about what we're talking about, especially as it pertains to clinical trials, we know in the adult population, just sort of across the board of adults who have been diagnosed with cancer that participate in clinical trials is very low. And then when we're talking about this racial and ethnic minorities, it's even lower than that very small already number. But then it makes me think about some of the systemic issues that are also associated with that, right? Because really, regardless of where you are on this socio sort of economic scale, navigating clinical trials and one that might or might not be suitable for you is not easy, particular in the community setting, and even more particularly in the more rural community setting. Like finding this information and what might be best for folks who are interested or looking or who have been empowered to sort of go down this path because a clinical trial might be the next best option for them, is nearly impossible for most, right? And I'm talking about by the most, with the 80% of people being seen outside of an academic setting where the majority of these clinical trials are actually happening, right? So systemically, there's even a larger sort of issue that goes along with that. And I know at GoTo, one of our big goals is not only to create education and empowerment materials that are at literacy levels that the majority of folks can understand, but also make them easily findable and accessible, right? Easily understandable, and then easily usable. Like, it's no use giving people all this information if they can't find it, they can't understand it, and then they don't know how to use it after they do finally find it, right? So anyway, I kind of jumped down a sort of rabbit hole there, but I think it's an important piece of this, because clinical trials are an important piece of discovery and treatment, that I think is often overlooked for various reasons. So Dr. Henderson, I want to kind of jump back to you and talk a little bit about this evidence-based information, on which communities are impacted the most. Can you talk a little bit about that for us tonight?
Yeah, of course. And I always like to start with the disclosure that these things are really not comfortable for people to hear or talk about. But I think that the most growth comes from uncomfortable conversations and actually hearing about it and seeing it. And most times people, they want to know why this is important. Just kind of a high level overview. Cancer is very heterogeneous, is what we call it, right? As scientists and people in the field, but it just means very different. Right, so everyone's cancer is very different. Cancer affects different communities differently, and we see that within certain communities. For example, we know that 1 in 16 Black men and 1 in 20 Black women will be diagnosed with lung cancer in their lifetime. All right, and Black men are getting this at a higher rate. This is in the United States, according to the NIH, specifically the NCI within the NIH. We know that Black men and women are significantly less likely to be screened at an earlier stage. We know that if the cancer is caught early, we're able to kind of, hopefully stop that cancer from spreading. Is what we call metastases. So stopping that cancer from spreading, or having a treatment that's likely to have an effect or likely to be curative in that community. So if we're not being, the cancer's not being caught early, and we're less likely to catch that cancer early, you can imagine how the death outcomes are. And so Black men have the highest death rates of lung cancer in the United States compared to the majority. And so understanding all of these numbers and why they're important is because cancer is very different, and cancer affects every community differently, just as it affects every person differently. And so understanding that different communities are affected and impacted differently by lung cancer specifically, I think we can take a deeper dive into understanding how we can, number one, get the word out on this. Number two, create some type of awareness so that we can kind of change this. And I believe that, health disparities is a marathon. It's not a sprint. We're not going to cure it in one day. We're not going to fix it. But understanding all the puzzle pieces that goes to this giant picture that we have of health disparities kind of help us have an understanding of how we want to combat it.
I think that's so important, and I'm posing this question to sort of all of you, particularly as it pertains to the Black American population, where we know, as you just said, Dr. Henderson, the evidence shows a higher propensity, particularly for lung cancer. And I know we're going to get into some general sort of, low-hanging fruit solutions and how we might be able to start. To your point, we're not fixing this overnight, but what are those things we can kind of run to? Why do you think, outside, and maybe it is just what we already discussed, like why do you think in particular in the Black American population the propensity is so high?
Well, I think we have to, we'll be here all day if we start back from the history of the country and understanding how we were withheld from proper health care, how the kind of going into what redlining is, and how the United States is mapped out as far as certain communities, thinking about things like food deserts and even socioeconomic status. And I don't like painting the broad picture that every Black person is the same in the United States. That's not true. But understanding that the history behind of how we were treated from a healthcare standpoint throughout the beginning of this country makes it's like we're playing catch up. And that's why I say it's a marathon, not a race, because we're trying to undo years of mistrust, years of mistreatment to kind of meet at the middle. And I think we're starting to understand this. And I think that the conversation, and for me, as kind of an early career guy, for me, I feel like this conversation has just become really, really important. in 2020, when things started, the world started changing and these conversations started happening, even and it emerged from social justice to health. And so now that we're having these conversations, we can start to unpack these things. But to answer your question broadly, I think it's years of just kind of mistreatment of the Black community in the healthcare sense, and how we withheld some of these things. And I could go on and on, but I'll stop and just kind of let someone else take it, because we could even go into how just recently, we're starting to include African American cells in research, right? Before it was only cells of Caucasians, and you can imagine if cancer is so different from a biological and molecular level, we should be studying all different types of ethnicities, right? And so I'll stop there because I don't want to get on my horse and keep going, but I'll stop there and let one of my colleagues take it.
Yeah, I think you've made very important points. Dr. Dagogo-Jack, do you have anything you want to add?
Yeah, I was just going to comment on things that perpetuate the disparity, right? We've talked about screening, right? And so we say the numbers like only 5% of people who are eligible are screened. But if you look, there's significant geographic variation in terms of who is screened, right? In New England, there's higher rates versus the places where people have higher rates of lung cancer and people are dying more frequently from lung cancer. There, the screening is kind of, for lack of a better word, abysmal, right? And then you have to think about where screening facilities, where access to CT scans, are they in the appropriate communities? Are the physicians in these communities? Because most people are not traveling to academic centers to receive their care, right? Are the community physicians empowered enough to have these conversations? Do they have the appropriate resources and the infrastructure to follow up on the findings and the appropriate referral basis to send patients to get the appropriate care? And then let's say you found a nodule now, right? And you think someone has a stage 1 lung cancer. Are they having the right conversations with the surgeon? Or is the surgeon kind of introducing their implicit bias and saying, I don't think this person is going to stop smoking. Some surgeons say stop smoking before you have surgery, right? I don't think this person's going to stop smoking. Let's just send them to a radiation oncologist. Let's just kind of find a different path, right? All these detours along the way, I think, lead to the point that you get more advanced cancers in certain populations. And then also when you have these more advanced cancers, we also find disparities in terms of the things that save lives, right? Or prolong life expectancy, molecular testing. There was like a great study a few years ago by Deborah Bruno and colleagues that was presented at ASCO, really just showing that a disproportionate frequency or prevalence of molecular testing, if you look at kind of the Black patient population versus Caucasian patient populations, and then also how that fed into clinical trials, which we've been talking about now, right? You can't tell if someone is going to qualify for a clinical trial if they haven't had the testing. So these are just things that perpetuate, I would say, structural things that I think that we can, a step at a time, try to tackle some of these things.
I agree.
Yeah,
Dr.
I'll
Baskin?
just add on. Yeah, I'll just add on just a little bit there. I definitely would pick up on, what we know as the disparities it is related to mortality. And so what we know about that is that typically individuals, Black Americans, are being diagnosed at later stages where the options are much fewer and the chance of survivorship is much lower. And so when we think about what are the barriers to getting, earlier diagnoses, it is absolutely, the literature suggests that, you don't have these facilities for low dose CT scans in communities of poverty or in marginalized communities in rural areas. And so not having that is a significant barrier. The other thing that we learned, for a number of years, I was in the Deep South and we did that work before I moved to Pittsburgh. And in the rural areas, we also found that one of the other structural barriers were primary care providers not being up to date on the current guidelines. So that conversation from earlier, we were talking about needing to have a physician to give the referral. They, would often, what we find in the local communities is that people say, oh, well, you haven't been smoking in 20 years, despite the fact that had, smoked, a chain smoker all of your, from adolescent through adulthood. They're not up to the guidelines to recognize that, yes, this person still is at higher risk and should go to that scan. So I think those are barriers. And then the last, more cultural, going back to our other conversation around norms, at least in the populations that we worked with, for a number of years, in the community, many of the individuals that we work with, still see cancer as a death sentence. And so many were not wanting to find out if that, if that start spot on the scan was cancerous. So they wouldn't want to follow back up, because they felt like that immediately meant that they were going to be dying. And so we've tried to do more education, talk about the importance of early detection and about getting options for screening. But I think there's still some cultural norms about cancer that we have to overcome, and certainly make those treatments available, more equitably available to them, if in fact somebody does have a cancer diagnosis.
I
Yeah, and I'm
think
actually
all,
kind of add a, oh
sorry.
no, I was just going to add a comment about the cultural norms and have those conversations and people not wanting that death sentence or equating cancer to a death sentence. Sometime within certain communities, talking about health is really taboo in certain communities, and so some families just don't want to talk about it. I think now generations now are really taking the lead with, hey, discussing family history, whether it's diabetes, whether it's high blood pressure, whether it's cancer. And so me understanding my history of prostate cancer, I'm making sure the people in my family are getting checked at an early age or at the recommended age. And for us, it has to be a little earlier, because we have that high prevalence of family history. And so breaking the cultural norm of not talking about health, I think that's going to change a lot going forward, because we can put into people's faces and make it a little bit more comfortable, although it never will be completely comfortable talking about these things. I think that's an important start. And so Dr. Baskin, that was an excellent point.
Yeah, I agree. And I love this part of the conversation because I think we're sort of touching on and digging into some of these things that to some degree really sort of cross cultures, right? When we're talking about mistrust, we haven't talked about stigma, but the role that stigma plays, particularly as it pertains to lung cancer, and denial, because this fear of death, especially when it comes to lung cancer. I know, back in the 80s and 90s in particular, there were a lot of really great sort of anti-smoking campaigns out there, but they really put this humongous fear into people who were, especially those who are heavily addicted to tobacco and maybe don't want to quit. And they know in spite of there's, anyway, that's a whole other sort of conversation when we look at that sort of thing. But I think it's so important. And then it kind of circles even back around to what I think you said, Dr. Baskin, about the primary care providers, right? I mean, these are the people most often seen, like, I broke my arm or I have a sore throat and strep or something like that, but not having these conversations and a quick sort of derail. And I know I've brought this up in other living rooms before, particularly as it pertains to screening. You're sitting, how often do you go to the doctor for one thing or another, and you're sitting either in a waiting room or in the actual room where you're going to have your visit itself. And big, huge, beautiful poster on the wall, starting from infancy and running through really end of life. And here's everything. Here's when your babies need to be vaccinated. Here's when you need this. Here's when you need to be screened. Here's when you need to start getting flu shots and all of it. This was well into approvals for lung cancer screening. Nothing on there, right, about lung cancer screening for that sort of, well, then it was 55, but 50 and over sort of spot. And I thought, wow, what a missed opportunity for somebody like me who's just sitting there for 30 minutes waiting for my doc to come in to kind of find my age group and figure out what I should be doing. So I think it's sort of, like I said, multifaceted, and there's a lot of really great conversation that's coming out.
I would
So,
just add to your
mhm,
point, just sorry to interrupt. Again,
no,
I recognize that there's all sorts of, again, talking about social determinants of health. We're moving towards this telemedicine age and this kind of computer age where patients are directly able to access their medical records. And I found that has really changed the conversation. I have patients who now, you may not see that poster on the wall about lung screening, but have patients who are savvy enough to go into their chart who are like, oh my goodness, I saw that I was behind on all these vaccinations, on all these tests, and they're bringing these conversations up now. So I
yeah.
think that as patients are starting to interface more with their health and owning it, I think it's an incredible opportunity to kind of build up, I guess, some of these things that we're talking about, and also improve the language with which we communicate to patients in the charts, just so they're aware of what tests we recommend, what we're talking about, right? I think there's been emails where I get from patients who are like, can you clarify what this meant? And it's made me take a step back and kind of think about how I'm communicating with what I'm typing in my notes and other things. So I think it was a struggle initially to adjust to, but I think it's an incredible opportunity, actually.
Yeah, I agree. I think technology, although it's come a long way, we still have a ways to go, right? To implement some of those workflows from physician like you who's working in the clinic to how can I best communicate whatever these findings are or whatever information I need to pass on to, patient X, Y, or Z. How can I best make that happen? Because we also know that in a very large majority of this country, people don't have access to the internet, right? A lot of people have cell phones, so they might have cellular data, which is great, and quite often that helps to guide them towards the access. But even in the realm of screening, I think one of a big frustration for me, and I'd love to hear any thoughts you all might have on this, is the workflows around screening protocols, right? So let's assume we can get somebody in the door for that first time because they qualify and they need follow up in a year or 6 months or whatever that follow up might look like based on what we find. How do we get them back there? Because quite often they got on a bus to get there the first time, right? And what does that communication schedule look like to ensure that not only we're reminding them, but we're supporting them in getting back to where they need to be? I mean, do you guys have any thoughts on that? Because screening for lung cancer is complicated.
Yeah, I would definitely agree, and the work that again that we targeted rural areas in the Deep South and really utilize a community health advisor model and community navigations model to be able to help those individuals in the local community to move from step to step. And what we saw systematically is that we lost people at each one of those steps. It's so complicated of a process. You've got to go to a primary care provider, convince that person that you need the referral, or they give that over. Then you've got to go to that scan, you got to wait for those results, you might have to go back for a biopsy or some other follow-up, and then you've got to find treatment. And unfortunately in our country, especially in rural areas, more and more providers and opportunities for healthcare are closing, and there's an even greater shortage for primary care providers in those rural areas than there are in urban areas. And so part of the step is, I think, navigating, just helping people to know so they don't fall through the cracks at one of those steps, and helping them to know what resources are available, including social services, making sure they're maximizing their eligibility to health insurance, and then also, partnering with providers that are willing to give low cost types of treatment and ensure that we don't lose people after they've gotten a diagnosis. So I think it is a very complicated system there. And then you add on layers like the previous conversation around issues of literacy and access to technology. It's no wonder that we see the disparities where certain populations can benefit from the technology and the great, genetic counseling and so forth, and others absolutely cannot.
Yeah. Yeah, and I think looking at that and not even just health literacy, but even language barriers, particularly in the United States, right? Spanish, whether it's Chinese, I mean, you name it, we've got a multitude of amazing humans in this country who English is not their first language. So how do we communicate to them? And again, the four of us could talk about this for the next 6 hours and not have any potential solutions that's going to fix the totality of this problem tomorrow. But I love the fact that we're talking about it now. So I'm trying to be mindful of time. I'm keeping my eye on the clock up there. And I know we've touched on a couple of potential, immediate and practical solutions to combat some of these social determinants of health as well as medical efforts. And I think I just want to kind of reiterate, what we're talking about here. We're talking about, cultural barriers. We're talking about poverty. We're talking about food insecurity. Literally, people don't have access to food, yet now they have to try to figure out how they're going to pay for their health care. discrimination, lack of access to quality education, stable housing, quality healthcare, among many other things. I think there's potentially multifaceted approaches to, to start sort of picking away at this. So, what do you all think? And Dr. Baskin, I'm going to start with you. As far as like outreach and engagement, like what is some of that low hanging fruit and these, like I said, practical solutions to start to chip away at some of these problems?
Yeah, I think, from some of the structural issues, I think, making sure that we have campaigns to better educate primary care providers about the current guidelines. Perhaps we can, redo those wonderful posters that you're talking about and put in the age appropriate screening for lung cancer. I think we also, in addressing those social determinants, we've got to do a better job of linking providers with some of the social services to ensure that people can maximize, benefits related to transportation and other barriers that might keep them away from getting that care. I think that's really important. I think there's also a room for educating the larger population around things like clinical trials. I mean, honestly, I'm biased. I sit at a comprehensive cancer center, but I know that that is part of that continuum of high quality care to have people to have access to those additional treatments when standard treatments are not really working. And so we really need to kind of advocate for better advertising, as you're saying, so that people know what those trials are, as well as incentives for the large academic medical centers to partner with the smaller community cancer centers to ensure that those patients have access as well.
Thank you. Dr. Dagogo-Jack, I know you being someone who works in the clinic, and I know you're doing a lot of work to try to implement within your own hospital setting um, some best practices to sort of help, again, chip away at this problem. Can you talk a little bit about that?
Yeah, just piggybacking on what was said, I think that we have to meet people where they are and take advantage of the opportunities we have. So, what I mean by that is, I think that it is impractical to assume that the best healthcare is going to be at these kind of academic medical centers, that everyone should be battling traffic to go there, right? I think it behooves the academic medical centers to expand their reach, right? To multidisciplinary tumor boards and leverage this virtual revolution that we're in currently to make sure that just because you're living somewhere else means that you have disparate care. The other way that I think that we can tap into this is emergency rooms, right? And so a lot of patients, if we think about lung cancer diagnoses, we have ways to go with screening, but incidental pulmonary nodules are really an incredible opportunity. And I've heard pretty innovative strategies that people are doing, like partnering with emergency room physicians to make sure that there's a navigator who comes right to the emergency room. If there's an incidental pulmonary nodule, they plug you right into a clinic, they talk to you about what it is, and they facilitate through that approach kind of early management and early detection of lung cancer, because there's so many patients who fall through the cracks, right? They come for a UTI or something. They're found to have a pulmonary nodule. No one tells them. 3 years later, they have metastatic disease. So I think that's an opportunity. We can meet them where they're going and meet them where they are.
Yeah, I love that you brought up the IPNs, or the incidental pulmonary nodules. I know that go to through our Center of Excellence program in particular has a very specific designation dedicated to IPNs and helping community centers throughout the country, including in rural communities, to develop and implement these IPN programs and workflows. Because you are right, being someone who for the last 16 years has been on the other end of the phone from people calling in from all walks of life, not even just from this country, but around the world, the amount of times I have heard, yeah, well, I was diagnosed with late stage lung cancer, but lo and behold, somebody went back and saw some scan that was done, X amount of years ago, where, I had a, 6 millimeter nodule, and that was it. So it I think is such an important piece. Okay, so again, we've got like 9 minutes left. If I could ask you all just sort of one more question, we didn't get into some of the potential long-term solutions. Maybe that'll be a part 3 to our health equity and really talk about some of the systemic changes that need to be implemented. We touched a little bit on the IPN, but I mean greater from from not only the access to healthcare, but the health coverage and like who's going to pay for this and all of that. But I do want to ask each of you this question because I think our listeners and our audience would like to know. So, in your day-to-day work, each of you individually, what role do you play in working towards improving health outcomes for people who fall within these populations that we've been talking about? Dr. Dagogo-Jack, I'll start with you.
Well, I think so. I see a variety of diseases in the lung, including mesothelioma, which is something that I think really it impacts kind of, I would say, a variety of communities and not necessarily the most resource communities. And I also serve in our thoracic group as the person who sees most of our patients who are and kind of on the islands, right? Who don't necessarily, they can't commute to Boston all the time for care. And so I've really had to think about kind of how to implement telemedicine, but at the same time, making sure that people have the right type of care and that we're not kind of missing out on diagnoses and giving subpar care just because someone can't come. And so giving kind of second opinions through that strategy and things like that. And again, I recognize that there are barriers to doing that across state lines, but the way I've been able to do it is to get multiple licenses across state lines. Hopefully in the future, we can improve those things. But in my clinical practice, that's how I've kind of tackled it. It's a small step. There's a lot of work left to do, but it's what I'm doing day to day.
It is a small step, and I think like even if we could find silver linings in the whole pandemic and COVID, some of those state lines and that sort of thing were softened right during that time, so that people could get access because everybody was stuck at home. And so I'm hoping that maybe there's some lessons learned there that will find their way to the future of what this telehealth or this remote sort of medicine might look like. Dr. Baskin, how about you?
Yeah, I think there are probably three things that I would say on a daily basis that I'm focusing on. I think on the prevention and early detection, it's really making sure that we are engaging in the communities that our cancer center serves, and focusing on outreach and education to make sure people are aware of age appropriate screening and getting them in to be screened. I think the other thing that I concentrate a lot on is increasing the diversity in our clinical trials, because we need to know about what treatments work for a diverse population, and we're hard pressed to know that, as Dr. Henderson was talking about, because most of our trials do not reflect the diversity that exists in the United States. And then lastly, I think one of my other leadership roles, I really am, helping to try to bring about greater diversity among our providers and our researchers. So making sure that the providers that are available are also reflective and representative of the U.S. population, which at this point is far afield from that.
I could not agree more. Dr. Henderson.
Yeah, I think me and Dr. Baskin are doing the same things as far as increasing representation within the field of oncology. I think you can imagine going into a clinic, the likelihood of someone of color, specifically a Black person, going in and seeing someone who looks exactly like them, a thoracic oncologist, is very slim. So understanding that, increasing representation, people who are closer to the problem and closer to the solution. So people of African American descent and Black, so we understand like things that we go through and understand the ways that we can communicate with our own community to increase, better outcomes within cancer. So that's number one. Number two, so I educate physicians on comprehensive genomic profiling, which is basically molecular profiling. Every cancer has a report card. And so by report card, I mean certain genes that are most paired with specific targetable agents. And so I make sure I keep physicians up to date on the CGP guidelines and make sure they're making the best decisions for their patients as well.
Fantastic. And I think, I'll go next from an advocacy perspective. we ask ourselves all the time, what role can go-to and advocacy in general play in this health equity piece? And I think, as we've heard you all discuss tonight, and we heard last month, and we're going to be continuing to hear for years to come, reducing health disparities to improve health outcomes is a complex challenge. And I think from a go-to perspective, outside of what we're currently doing insofar as ensuring that our health education is, at a low literacy level, we do provide the living room post live in Spanish and simple Chinese subtitles to try to target, some of those populations. We do have internal navigators who help folks who are interested in finding clinical trials that they may qualify for in their area. Among other things, we have partnered with an organization or a company called FSG to really look at and identify lung cancer disparities in all race and ethnic groups and marginalized populations. And we completed phase 1 in 2022, and that was really a literature review and qualitative research and interview panel. The effort being really to define and understand some of these access barriers and inequities across the lung cancer continuum for the historically medically underserved communities. And then launching early in 2023 is sort of our phase 2 approach to really look at that internal and external assessment and framework development and implementation planning. So we're really going to, what did we learn from phase 1, and how do we, take that and implement it into a foundation-wide health equity strategy? So those are a couple of the things that we're doing. And we've got, a couple of minutes left. If anyone has any final thoughts or take-home points, like if in one sentence or 2 sentences or less, what do you hope that people kind of grab onto and heard about this discussion tonight? Dr. Henderson, I'll start with you.
Yeah, I would say number one is don't, be scared to have the conversation or even to just listen and understand. A lot of times people, when you think about health disparities and health equity, most people just automatically assume race, but there's more than that goes into this giant quilt, like I mentioned earlier, of health disparities. So not being afraid to just start the conversation, have the conversation, and listen and understand. I think everyone has something that they're a little bit ignorant about. Me, myself, all the time, sometimes I can't cook that great, but I listen and I learn. So understanding, the role that we all play, and just having an active ear and being an active listener to stories and listening to people's problems. I think that's an important way to kind of start the journey in kind of combating health disparities and gaining health equity.
That's great. Thank you. Dr. Baskin?
Yeah, I will just pick up. I think, the main thing to take away from this is that we've got to start talking about it. So I think talking, with family members, getting that family history, talking with providers to, let them know and have that informed decision making about where to go. And I think talking with policymakers and other leaders about the need for improve resources within communities that are more marginalized, as well as we need improvements in the representation that we've talked about with clinical trials and in the biomedical workforce.
Fantastic. Dr. Dagogo-Jack?
Yeah, I would just say at the individual level, what can we all do? I think that Dr. Henderson has said it, right? I think that we should embrace feeling uncomfortable. I think we should reflect internally. We should seek a multitude of kind of experiences, a variety of perspectives. I think that's how we kind of unravel whatever biases we have internally and kind of reframe and shift our framework. And so I would just encourage everyone out there, like, do something that makes you uncomfortable, right? The things we've talked about, if they make you uncomfortable, go read about it, right? Go volunteer in a community you might not have thought. It's the holidays, right? That you might not have thought of volunteering, and you'll learn so much. And I think that it really gives you some perspective.
Yeah, I love that. And
I'll,
go ahead. Sorry.
No, she was saying that the Dagogo-Jack mentioned just to read about it. This is not a plug. I don't know this author, but a really great book if you wanted to learn more about health disparities and how and health equity and how it shifted to being considered a Caucasian woman disease, cancer, to now affecting multiple of communities. Is how cancer crossed the color line by Keith Walu. He's a professor at Princeton, I think now. And so it's a great book to just kind of read, and it's really digestible. So I've given it to some family members to read, and so great book to gift on a holiday to just kind of learn and educate yourself on how cancer has affected our community and our country in more populations than just one.
I love that, and I think it was how cancer crossed the color line, right? And we will most definitely, for our audience that is sort of native and more familiar with what we do here at the living room, we do follow up with a show notes, so we will be sure to link to that in the for anybody who may have missed it tonight. And I think the sort of general theme that I'm hearing from all of you, and Dr. Henderson had started this sort of earlier, was that most growth comes from the uncomfortable conversations. So stretch, let's all sort of stretch and have those uncomfortable conversations and activate. I mean, those conversations will lead into activation in some form or fashion. So I just want to thank you all from the bottom of my heart, from the bottom of this community's heart, from all the folks at GoTo Foundation. Thank you so much for coming here and being a part of this tonight. I want to thank Dr. Christine Lovely, who is the chair of our scientific leadership board and out there in Nashville, I think, watching tonight, for suggesting this topic for the programming, because I think it's all too important. And I think there is most definitely more to come. For us, a little bit of housekeeping before we close out for the night. Our next living room is January 17th, 2023. So between now and then, I wish everyone happy holidays and a happy new year. The topic for that is really going to be around getting to know your go-to team and the work that we and each department are doing that's impacting lung cancer care and treatment. To get regular updates on this program, as well as information on other GoTo Foundation patient programs and services, please join our patient caregiver community. And I think the link's going to show up on the bottom for you all. And then again, my heartfelt thanks to all of the panelists tonight, all of you who are watching live, or those of you who will come back and watch post live. Penn Media, who's on the back end of this, ensuring a seamless transition into your homes, wherever you are watching from. Michelle Zay, who's also always on the back end of this and oversees this programming, and really the entire GoTo team, without whose support and constant work every day, we wouldn't be able to get this done. I'd be remiss in not thanking our supporters: Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, DSI, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you all. It's a very long list, and obviously goes to show how important this programming in this community is. So happy holidays, everyone. Thank you all so very much, and we'll see you in the new year.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.